We have 206 individual bones in the human skeleton, grouped in two different divisions. We have the axial skeleton, which makes up 80 bones, and the rest 126 bones are found in what's known as the appendicular skeleton. The axial skeleton is comprised of the skull bones, which includes the facial bones and the cranial bones, 3 auditory ossicles, which are the smallest bones found in the body, the incus, the stapes, and the malleus, also known as the ear bones, the hyoid bone, which we'll find out articulates with no other bone in the skeleton, the ribs, the sternum, and also the bones of the vertebral column known as vertebra. The appendicular skeleton, which we'll cover in a different chapter, is going to include the bones of both the upper and lower extremities or limbs, as well as the girdles that connect the limbs to the axial skeleton. This link will take you to the Wiley Plus skeletal system. It's a very broad and general overview of both the axial and appendicular skeleton. If you just want to find out the names and locations of each individual bones, this is a great little resource for you to follow. Nice little study up before the next quiz on this chapter. We find 5 different types of bones found in the human skeleton. Basically, we have the long bones, which you may be familiar with from the last chapter. We talked about bones that have a distinct diaphysis, epiphysis, and metaphysis. This one you'll see on the skeleton here is the humerus. We'll go through the individual appendicular skeleton bones in the next chapter. You'll also have short or cube-shaped bones, most often found in the wrist. Flat bones you'll find here as the sternum, and also some of the cranial bones of the skull. You also find very irregular or complex shapes. Most of these will be classified in the vertebral column, including the vertebra, as well as the sacrum, the coccyx, as well as a handful of others. And finally, you have a sesamoid, which simply means shaped like sesame seed. This is your patella or your kneecap. You'll also find these oftentimes, although not in everybody, you'll find them in the tendons in the hands as well as in the feet. Typically, the sesamoid bones will be found embedded in tendons, which will actually give additional strength to the tendon itself. Next, in some segments of the population, not all, you may have what's known as a sutural bone. These are extra bone plates that can be found within the sutures of the cranial bones. Now, sutures are where 2 flat bones of the cranium will stitch themselves together. These are actual joints. They allow very, very little bit of motion there. And if you notice here in particular at the sagittal suture as well as the coronal suture, you'll notice that they're not flat approximations of both sides of the bone. It's almost like in a jigsaw pattern, which helps increase surface area to allow these to fit more precisely. There are ligaments that are found down within the sutures that knit the bones together. So in some cases, it allows a very little bit of motion. In particular, very important for protection of the skull in particular. It allows the bones to be able to impact some force, although not all, and be able to disperse it through the ligaments and disperse the forces altogether and prevent any kind of major injury. Now, we find on many of the bones different types of what we call surface markings. You've already found some of them when we actually did the vertebral prominence back in Lab 1. So very simply, we see 2 distinct types that help us determine what kind of functions that the bone is going to be providing. So you find 2 different types of surface markings. One will be depressions and openings. These typically will allow the passage of certain types of soft tissues, including nerves, blood vessels, tendons, and or ligaments, where they may form joints. You'll have processes, which will actually be projections or outgrowths of the formed joints. These will be attachment points for ligaments and tendons. And as we touched upon in last chapter, typically, if we have a very strong muscle or a very strong tendon on a particular process, that process can actually grow up to a certain extent because of additional pressure being put on that particular spot. If we didn't have something like that, very soon the tendon could possibly pull themselves away from the bone and cause an avulsion fracture. It's this laying down of the process or laying down more calcium on the process. If you guys remember Wolff's Law, anytime you lay down a particular pressure along a certain line, it'll actually lay down more tissue, in this case more calcium at the process, to strengthen it against the major force. The first feature we'll look at here is what's known as a fissure. These are going to be narrow slits found between bones for passage of blood vessels or nerves. In this case, we're looking at the superior orbital fissure found deep within the eye socket. Through this particular fissure, you'll find the different nerves that will control the muscles for eye motion. Next, we have what's known as a foramen. This is a hole for passage of blood vessels, nerves, or ligaments. In this case, we're looking at the foramen magnum. What's significant about this is where the brainstem will continue out as the spinal cord as it travels down the vertebral column. A fossa is known as a shallow depression. Here we see the mandibular fossa, where the mandible will intersect and form a joint to form the temporomandibular joint, otherwise known as the jaw. Here we have an example of both a depression and an opening on a bone. A sulcus is known as a furrow on a bone or passage of blood vessel, nerve, or tendon. Oftentimes we find this on the femur or the humerus or on the inner portion or the deepest portion of some of the cranial bones. A meatus is a tube-like opening. Here we see the external auditory meatus. The ear will be covering just that. And of course, if we have an external, you assume we also have an internal auditory meatus. This is all continuous. This is for the vestibulocochlear nerve and the associated veins and arteries. Here we have a condyle. These are rounded projections on a smooth articular surface. This allows a nice, clean, smooth range of motion for the particular joint in question. We'll be looking at quite a few different types of condyles as we get into both the axial and the appendicular skeleton. A facet is known as a smooth, flat, sometimes slightly concave articular surface. In this case, we're looking at a superior to inferior view of a vertebra. This is going to be a thoracic vertebra, which I'll explain why in a couple slides down the way. So very simply, these allow each bone to slide upon one another within a certain range of motion, limited by ligaments and also by muscle tension. In some bones, such as the ribs, the humerus, and the femur, we will have a head and a neck. Where very simply, the head will be the rounded articular portion, supported by a narrow portion of the bone known as the neck, very similar to what we have throughout the cervical spine as well as the skull. Crests are going to be prominent ridges or elongated processes. These are going to be primarily tendon attachments. So as you can see here, this is known as the sacrum. This is going to be the median sacral crest found in the most posterior portion of the sacrum here. There's going to be different gluteal attachments as well as other smaller muscles that range throughout the posterior part of the pelvis. Just like the crest, there will be other types of projections we'll have as well. These are usually roughened projections. We have what's known as an epicondyle, which will be found just usually lateral or superior inferior to the condyles. These will be different in the sense that these will be roughened. So in other words, this allows more for tense attachments for the muscles themselves to the bone. They're only found on the humerus and the femur, which we'll look at in the next chapter, but we throw this in here as just as the general surface markings anyway. We'll often find lines as well, which will be long, narrow ridges or borders, less prominent than a crest, but fairly close to it. Here we see a nuchal line, both superior and inferior, on the occiput. This is the posterior portion of the skull. We also find these on the posterior portion of the femur. We also find other long bones here and there, mainly for a very long, very broad muscle attachment. And in particular, when we look at the vertebra, each vertebra will have a spinous process which will project posteriorly. It's a very slender projection that allows for muscle attachments as well as ligamentous attachments. This is what we were palpating back in lab 1. Some of the vertebrae also have transitive processes as well, both left and right. These will project laterally instead of posterior like the spinous process, but these also will have different ligamentous and tendon attachments. In some cases, they actually have an articular surface, especially for the thoracic vertebra, where they'll attach to the adjacent rib. The trochanter is very special. It's only found on the femur. We have both a greater and lesser, which I'll show you next chapter. We also have tubercles. These are very variably sized round projections. These actually help limit certain portions of motion. When we look at the jaw in particular, we'll talk about the anterior tubercle and why it's so important for that to be there for proper motion of the TMJ and how it will integrate in certain kinds of problems such as lockjaw. Next, we have a different type of process called a tuberosity. This is a little bit different from the crest. It's a little more rough, a little more of a bumpy surface, a little more irregular. This will help kind of limit certain types of motion between two bones. In this case, we're looking at the sacral tuberosity. This is the lateral portion, also for muscle attachments, but also to help kind of cement almost the sacroiliac joint to allow certain type of motion and not allow too much ligament laxity. So moving on to the skull, we know the skull contains 22 bones, not including 3 bones of the inner ear. Basically, the 3 bones of the middle ear we'll talk about mostly in chapter 17. We get into special senses. We'll talk about their particular function as well as how they articulate. But basically, the different bones throughout the skull, we're going to talk about different types of processes, ridges, lines, depressions, and foramen. And we're going to further classify the skull bones into either cranial bones or facial bones. What I find to be very helpful is to have either your text open to a certain portion of the diagram or have a separate diagram printed next to you. If you'd like, there's also the lab that we're presenting for lab number 6. For the axial skeleton has a very good breakdown of each individual cranial bone, facial bone, with each individual lines, depression, foramen, and so on and so forth. So it's a nice little study guide to work side by side what we're doing here. The only downside I see with the textbook is it does show you quite a number of bones all in one particular shot. We're going to look at anterior, posterior, lateral. We're going to look at interior lateral, as well as inferior views. It tends to get a little bit overwhelming because you're only looking at certain types of depressions or lines based on the bone, based on the view you're looking at. For some people, looking at individual cranial bones, individual facial bones with its own particular features may be more beneficial, may be easier to remember. But unfortunately, this really does come down to memorization. So I do encourage those of you that are in lab to work with the bones in lab, whether it be the plaster or the real, and basically just kind of feel and kind of palpate again where all these depression lines, frame, and so on and so forth are going to be found. So first we're looking at the anterior view of the skull and the facial bones. And very simply you see that the frontal bone is going to dominate the most anterior as well as the superior portion of the skull. And it's going to round out laterally by the parietal bone and also the temporal bone. But the primary focus we're looking at through here is going to be the eye orbit, as well as two other features that I'm going to label here that are labeled in your lab but not labeled on this particular slide. The first one I want you to add is known as the glabella, G-L-A-B-E-L-L-A, found just superior to the nasal bone, which will be found right in the most medial portion and central portion of the skull that we're looking at here. It's the round projection between the two eye orbits. The second thing I want you to notate is if you look at where it says mandible, where it actually points to the middle portion there, that is known as the mandibular symphysis. This is where the two left and right jaw, as the jaw is forming in utero, will fuse at that particular point. So again, the mandibular symphysis is going to be found just in the middle there, where it literally labels mandible. Now, this can be overwhelming. What I usually recommend to most students is to basically learn the bones first, and then go back and then look at different types of framing that are going to be found there, the fissures, and so on and so forth. So I already mentioned a few bones here, including the frontal, the parietal, and the temporal bones. You're going to find the sphenoid bone found deep in green. That's going to form both the floor of the cranial vault as well as the most posterior portion of the eye orbit. One thing I do want to point out is it is very important to know the different bones that make up the eye orbit. So if we're looking at the right eye, so this is going to be on our left side, but it's going to be the subject's right side. You're very simply going to have the maxilla in yellow. You're going to have the lacrimal bone, the ethmoid bone, the palatine bone, the sphenoid, the frontal, as well as the zygomatic bone are all going to form different parts of the eye orbit. Very helpful to remember that may actually be a quiz and or a test question later on. Now, what you'll have to do is either study this particular slide or go back and look in the lab and go by each individual bone and note what kind of characteristics it might have on that particular bone. These slides in particular, not from the lab, these from the textbook and from Wiley Plus, are gained for both the quizzes and also for the exam. Here we have a lateral shot, in this case the right lateral view of the skull. So it's a nice shot of most of the bones that form the cranial vault. So again, going from the anterior to the posterior, you have the frontal bone in blue. The parietal bone will have the majority of the superior and lateral portions of the skull. The occipital bone, which was missed on the anterior view because it is the most posterior, is going to take care of the posterior and also the floor of the cranial vault. And then again, lateral will be the temporal bone as well. The sphenoid bone we see there is going to show a lot more features internally, and also the ethmoid bone will complete the entire cranial vault. But this also gives a nice little shot of how the cheekbone is oriented as well as the temporomandibular joint. So you see a bridge between the temporal bone and also the zygomatic bone. By the temporal process on the zygomatic bone and the zygomatic process on the temporal bone will meet together to form the zygomatic arch. This actually creates a hole for where the mandibular muscle as well as temporalis muscle will pass through to attach to the jaw. As you can see, there's the external auditory meatus found on the temporal bone as well. You'll see different processes that will branch off these as well, one of which, the mastoid process, you can palpate on your own just behind your ear. There's a little bump there. As well as the styloid process, there's going to be a ligamentous attachment as well as a tendon attachment for different muscles of the neck. But you do see the rounded portion of the mandible that's going to fit nicely into the condyle in the mandibular fossa of the temporal bone. You see the anterior tubercle is just adjacent to that, to the anterior. Also of note is to look at the side view of the eye orbit. You can see the smaller bones there, including the lacrimal bone and the ethmoid bone, which helps form the most medial portion of the eye orbit. Again, this is also another slide that's very important to know not only the bones themselves, also be able to identify the sutures and be able to identify different foramina and different types of processes found therein. Here's an internal view, sagittal section of the skull. So you can see a nice shot of all the bones that form the actual cranial vault, which also makes a very good test question. So if you're going around starting at the frontal bone and start working your way both inferior and then posterior, you have the frontal bone followed by the ethmoid bone, which is very important because your olfactory bulb will lay just there. Then with the sphenoid bone in green, which is going to be the centermost portion of the cranial vault, that will be continuous with both the temporal bone, most lateral, and then the occipital bone, and also attached to the parietal bone as well. So those are 8 bones that form the cranial vault. So you have 1 ethmoid, 1 sphenoid, 1 frontal, 1 occipital, 2 temporal, and 2 parietal. You also see a bone that is not easily seen in the frontal view. Something you see on the posterior view when you take away the spine is the vomer. This is going to be attached to the palatine bone as well as the maxilla. This is going to be a vertical style bone for muscle attachments, also for the nasal concha, to basically allow for air passages through the nasal concha and down to the throat. Also of note, you can look through the different sinuses, which we'll look at a little more thoroughly in the next couple of slides. You see sinus in the frontal bone as well as the sphenoid bone as well. These are air-filled pockets, usually lined with mucus. Those of you who have any kind of sinus issues, you definitely know that once they get clogged, the head starts feeling a little more heavy as well. Nothing I'll point out too, the temporal bone, which seems to be a very unique type of bone. There's a lot of different features on this one. There's your internal auditory meatus, which will be continuous with the external auditory meatus. Those of you who remember from Lab 1, the external occipital protuberance, there's also an internal we're going to look at. We look at an inferior view of the cranial vault. There's a posterior view of the skull and portion of the facial bones. In this one here, you're going to see the occipital bone will predominate the posterior portion of the skull. This one shows an example of sutural bones, which you'll find 2 small plate-like bones there. Not everyone has these. These are only found in a certain percentage of the population. We see the 2 large parietal bones that take care of the most superior and also a portion of the lateral and portion of the posterior cranial vault. You see the mastoid process on the temporal bone. This is a nice shot by taking away the spine and the spinal column. You see the vomer again, just the top of the palatine bone and the mandible and the maxillary. You can also see a portion of the back portion of the mandible as well. You can kind of see a little bit of the mandibular symphysis, almost a stitching of the 2 left and right portions of the mandible. Now, 2 other bones that people miss oftentimes are going to be the inferior nasal concha. Now, these are going to be paired with both the middle and the superior nasal concha, which we found on the ethmoid bone, which I'll point out a little later. These are going to help improve airflow through the nasal sinus as it passes through the nose and down through the throat. Also want to mention here, you see the foramen magnum. This is basically going to be the opening for where the brainstem will change into the spinal cord as it pulls out of the occipital bone and down through the first vertebrae. So this will be continuous as one piece, and again, there's the foramen magnum on the posterior portion of the and inferior portion of the occiput. You see it passes just between both the occipital condyles on the left and right. This will be the first articulation with the first cervical vertebra. Here's an inferior view. Again, continuing with the occiput, you can see the occipital condyles on either side of the foramen magnum. The occipital condyles will be little rounded surfaces there to articulate with the first vertebra. You're going to look at the external occipital protuberance as well. You'll find both the inferior and superior nuchal lines, which we'll talk about more so when we talk about the muscle chapter. These are attachment points in particular. What's nice about this particular slide as well, it gives you a great shot of the inferior view of both the sphenoid bone as well as the temporal bones and the different foramen that will protrude from them. We'll go through these more so in lab, but basically these are going to be the entry and exit points for the cranial nerves as well as different arteries and veins. There'll be a handful of them that actually they're more vestigial from the sense where nothing really passes through them. A couple of them are actually going to be covered over by different types of ligaments. So for example, one of the openings found on the temporal bone known as the foramen lacerum. You find it listed on the right-hand side here. This is actually covered by cartilage in the adult skull. Oftentimes you'll find this will be exposed once the skull is dried. So those of you who are going to be in lab, I'll try and point that out to you in particular. Whereas the foramen lacerum in situ doesn't really show any kind of opening at all. Usually it's closed off by cartilage. Also, there's a nice little shot. If you look at the facial bones in particular, there's the vomer that's going to attach to the sphenoid bone as well as the hard palate. the palatine bone and the maxilla. If you look closer, there's the incisive foramen. That's for the mental nerve. You see the different sockets for the incisors. You also see a great shot of the zygomatic arch. That's going to be bridged between the zygomatic bone and the temporal bone. So again, this is where the masseter and as well as the temporalis muscles will pass through to attach to the jaw. Here we see a superior view of the cranial vault. This is a great shot to orient yourself as to which bones actually form the cranial vault and what forms the floor of the cranium at the same time. So we see the frontal bone, of course, in blue in the anterior portion. Nestled just in between that is going to be the ethmoid bone. You find the crista galli, which looks like the comb of a rooster or a hen. This will be an attachment point to different ligaments, attachments, also for separation of the brain. You'll find the olfactory foramina, which will have openings for the olfactory bulb to lay down its neurons through a mucosal lining at the ceiling of the nasal cavity. And there's also the cruciform plate as it attaches to the sphenoid bone. Now, sphenoid bone, if you were to look at it in an exploded view, or if you're fortunate enough to be in lab, it'll have different types of wings. It'll have a greater and a lesser wing. You're also going to find what's known as the sella turcica, which I didn't point out in the lateral view, but it's actually easily seen on X-ray, which I hope to show you at some other point. Very similar, this is where your pituitary gland will rest. So sella turcica is going to be formed by the tuberculum cellae, the hypophyseal fossa, and also the dorsum cellae. If you look a little further on the wings themselves, you find the different types of foramen as well. These are going to be exit and entry points again for most of your cranial nerves. We'll get more into those when we get into the cranial nerves and the brain chapter, as well as a few other chapters, which include some of the spinal cord nerves as it passes through the foramen magnum there. Also, you can see through the temporal bone the internal auditory meatus as well, and also in the occipital bone you find the jugular foramen where the jugular vein is going to pass through. Now here we find the only freely movable skull bone found in the human skeleton, known as the mandible. This is the lower jawbone. It's the largest and strongest facial bone. It's aside from the middle ear bones, which also are removable. They tend to oscillate on each other. We'll talk about those later on in the special sense chapter. But again, the mandible is the only freely movable bone with a synovial joint found in the skull. So a couple of features I want you to be aware of on the mandible. One, looking at the columnar process, notice how it's rounded. This will fit very nicely in the mandibular fossa of the temporal bone. You'll find the coronoid process just adjacent to that. There's going to be a major muscle attachment, as well as the mandibular foramen. This will be a passage for nerves, artery, and veins for the lower lip, gums, and also the lower part of the jaw. You'll find the alveolar process, which will be the sockets for the teeth. You'll find the mental foramen, which will be the exit point for nerves, blood vessels in particular. The other portion which you should be aware of is the ramus. This is the most vertical portion of the also posterior portion of the jaw. You'll find the body, which is the most horizontal portion. Of course, the angle is going to join both the ramus and the body. There will be another bone that looks somewhat similar to this called the hyoid. So I do want to point out, if I do show this up on the slide, naturally it will show the teeth. So if you see teeth on the lower jawbone, you know it's the mandible, and it's not the hyoid, although there is some similarities, which I'll point out to you and get to the hyoid bone. So now that we've looked at most of the skull bones, let's take a step back and just assume that we're an ER physician. An 8-year-old girl comes to your office after being struck on the right side of the face with a thrown softball. Now, this girl did not have a face mask on. The patient's face is swollen and red. The patient complains that it hurts when she squints and when she clenches her teeth. Describe what structures have been affected by the accident, and what possible bones could be injured, and what tests would you do? If this actually happened to me, this is one of my kids where this happened, having a softball catch with her coach. And unfortunately, the son was behind the coach when she threw the ball to my daughter, and basically the ball glanced off her glove and hit her in the face. So I'll kind of relate to you what happened when we finally got her to the hospital. So anytime we have to evaluate any kind of injury to the face, it's always important to know what particular bones form what structures. So in this case, knowing that it was a impact injury from the superficial to possibly to the deep, there's two bones in particular that make up the eye orbit that usually will not be injured in this way, but it's helpful to know what bones make up the eye orbit. So there's 7 bones that make up the eye orbit, including the frontal, the sphenoid, the ethmoid, the lacrimal, the maxilla, the palatine, and the zygomatic. Now, 2 of the bones are relatively deep. They form the posterior and also a portion of the inferior portion of the eye orbit. That's going to be the palatine as well as the sphenoid. So for our purpose here, we're pretty much going to rule out those 2 particulars. So the ones that form more of the outer periphery of the eye orbit are going to include the zygomatic bone, ethmoid bone, lacrimal bone, frontal bone, or the maxilla. So here's the problem. Anytime you suspect any kind of fracture, naturally you do not want to palpate, in particular when you're around any kind of soft tissue. So in this case with the eye, you don't want to palpate around the eye if at all possible. The first thing you want to do, anytime you notice any kind of problem with a bone, you want to rule out any kind of fracture first. Usually either a skull x-ray or a CAT scan is oftentimes considered. The CAT scan is beneficial from the sense where it can also evaluate some of the soft tissues at the same time. So in this particular case, a CAT scan was ultimately done. Fortunately, the results were negative for fracture or pathology. Pathology means any kind of disease type of process or any other type of degradation of any particular body part. The patient was diagnosed with a bone bruise and a temporalis and masseter strain. So there are other muscles that were also possibly affected as well, but in particular when she clenched her teeth and when she squints, the temporalis and masseter muscles, if not under tension, were being tugged on by other muscles. Fortunately, the patient was seen by a pediatric orthopedist who happened to be on staff at the time. Ultimately decided to do the CAT scan instead of the x-ray just to kind of see what was happening with the soft tissues as well. Fortunately, after talking with the patient, it wasn't a very strong throw. It kind of glanced at her face, but again, being that she was young and also small in stature, it was a good idea to get her to the hospital and at least evaluate what was going on there. So next let's talk about the sinuses. There are 4 bones that have the paranasal sinuses. These are going to be filled with mucous membranes. Very simply, these will help warm and also moisten the air as it passes from the nasal cavity down the trachea into the lungs. These also act as a resonating chamber to enhance the voice and also increase the surface area of the nasal mucosa through the nasal concha. Now, those of you, again, who have had any kind of sinus issues, oftentimes when these get clogged, it also changes the timbre of your voice at the same time. Also, they tend to create more weight, so to speak, in those particular bones in particular. So for a lot of people who have chronic sinusitis, a lot of times the head actually feels heavy and puts a lot of strain on the muscles of the neck, both the posterior and the anterior. So here are the 4 nasal sinuses. We find the frontal sinus, we find the ethmoid cells of the ethmoid sinus, we also find the deep sphenoidal sinuses and also the maxillary sinuses. Now so far we looked at mature adult skulls. Next I'm going to show you what an infant skull looks like, actually found in utero at the same time. Very simply, the sutures are not fully present as of yet. Right now they're actually formed as fontanelles. These are going to be mesenchyme-filled spaces between the cranial bones that are present at birth. They close up either between 6 months and up to 2 years of age. Very simply, those of you who have kids before or have had younger brothers or sisters, a lot of times you'll have what's called the soft spot, which is actually known to be where the anterior fontanelle is. So very simply, the anterior fontanelle is going to be in the superior portion of the cranial bones, just between the frontal bone and the parietal bone. We have an anterior fontanelle, one anterior fontanelle, we have one posterior fontanelle found just between the parietal bones and also the occipital bone. We also have 2 anterior lateral and 2 posterior lateral fontanelles that we found between the anterior lateral fontanelle we found between the frontal bone and parietal bone, the sphenoid and the temporal, whereas the posterior lateral fontanelle we found between the parietal bone, the temporal bone, as well as the occipital bone. So again, these are going to be mesenchyme-filled spaces, and they will be full of cartilage as well. And then once you get to a certain point, they will fully ossify and actually form different sutures that you see here. Naturally, they're named here as future cranial sutures. If I were to ask you these on a quiz or an exam, I'm more or less worried about what bones you see here, the frontal, parietal, occipital, temporal, sphenoid, and also what fontanelles are shown here. I'm not worried too much about the future squamous sutures or the future cranial sutures. Know very simply where the fontanelles are found, and also for the exam, know when they start to ossify, which I'll talk about in the next slide. Now, each individual fontanelle will close at different times. The anterior fontanelle, which is going to be known as the traditional soft spot, will close between 1.5 to 2 years of age, or 18 to 24 months of age. The posterior fontanelle will close roughly around 2 months after birth. The anterior lateral fontanelles, will be paired left and right, close roughly around 3 months after birth. The posterior lateral fontanelles will start to close around 1 to 2 months, but won't fully close until after the first year. Now, we have these fontanelles for 2 reasons. One in particular is during the birth process. You want the head to be somewhat malleable so it can be shaped as it passes through the birth canal. Oftentimes, you'll find some babies that have been vacuum extracted may have somewhat of a cone head. That is temporary. The body will eventually start to reform the head in its natural position. But you want that malleability to prevent any kind of issues with the baby traveling through the birth canal and actually being birthed. The second important feature for fontanelles is you want room for the brain to grow. You want the brain to be able to expand to its natural position and natural form. Any kind of impediment to that can definitely cause some developmental issues. This is also one of the things that actually will separate us from different types of primates, is we also have very weak jaw muscles in particular. So if you notice on those particular bones on the fetal skull, you do not find any ridges, you do not find any lines or any kind of furrows or so on and so forth, because it's still somewhat malleable. So very simply, look at some of the larger primates, like gorillas in particular. They have very, very strong, very large crest right on top of the parietal bones. This is because of the very, very strong muscle attachments to the masseter and also the temporalis. So it's that distinction between us and that particular type of primate, is not having those really strong muscle attachments clamping down on the bone allow our brains to expand. And naturally, there are a lot of other factors involved there too, as far as evolutionary processes go. But that's one of the things that we do see, is the ability for our fontanelles to be spaced out, to stretch as we start to grow. And as the brain starts to develop too, we allow the brains to be able to develop into what it needs to be with any kind of impediment. So next question, true or false? A new mother brings her infant home and has been told by a well-meaning friend not to wash the baby's hair for several months because the water and soap could get through the soft area on the top of the head and cause brain damage. Those of you who have kids or have any kind of younger brothers and sisters, or if you plan on having kids, you will find you'll get a lot of unsolicited advice. A lot of it is extremely imprecise and therefore untrue. In this case, knowing we know about fontanelles and knowing we know about the integumentary system, the fontanelles are going to be made up of mesenchyme and fibrous connective tissue, but the skin is still intact. We know the skin from the last chapter is going to be somewhat waterproof. We do lose some water and fluids from the skin. There's some absorption here and there, but for the most part, it does retain a lot of different fluids and such, and also protects the area from any kind of invasion of any kind of foreign substance or any kind of injury. So in this case, this question will be false. We know this is false because there is no hole there leading into the brain. We do know the fontanelles are made from mesenchyme and will form into fibrous connective tissue. It is waterproof between the fibrous connective tissue as well as the skin layers. It will not allow the passage of water to pass through, let alone any kind of soap. But the area does remain flexible and does allow for the rapid brain growth as the baby matures. Next, talk about the hyoid bone. Hyoid bone is going to look similar to the mandible, but will be distinctly different. Number one, the hyoid bone does not form any articulation, no joint with any other bone. In fact, it is suspended within muscles and ligaments just anterior to the larynx and the esophagus. So very simply, it supports a lot of muscle attachments to the tongue. It also supports muscles that are situated at the top of the larynx. It will have some very particular formations here. In particular, it has two types of horns, both the greater and lesser. These are both for tendon and ligament attachments. It does have a body very similar to the mandible. As you can see, though, there are no sockets for the teeth. Although in the greater horn, it does look like it has some rounded projections. These are not condyles. They're simply greater horns that actually allow for muscle and ligaments attachments. But again, this does look like the mandible, but it is not. It's simply just look for the alveolar sockets, which are not there. But I can see how sometimes this can be misconstrued for the mandible. Next, we look at the vertebral column, otherwise known as the backbone or the spine or the spinal column. It is made up of 26 individual vertebrae divided into 5 regions. The 5 regions include the cervical, thoracic, lumbar, sacral, and coccygeal areas, whereas the sacrum is going to be comprised of 5 fused vertebrae, and the coccyx will be formed of 4 fused vertebrae, so they're not starting off as individual bones. They'll be fused by the time of the age of 24. We have individual sacrum as well as individual coccyx. And then there are 24 other vertebrae that round out the vertebral column. These allow for protection of the spinal cord and also allows for spacing to allow the spinal nerves to branch out both left and right, and does allow a certain range of motion in through different areas. In particular, the cervical as well as the lumbar areas have more range of motion than the thoracic. The other thing we're going to look at too here, we're looking at a lateral, right lateral shot of the spinal column. You're going to see different curves here. You're going to see 2 kyphotic curves, which will bend towards the posterior, and 2 lordotic curves that will bend towards the anterior. So the 2 kyphotic curves that we have are the thoracic curve and the sacral curve. We're born with these, and as we start to develop and start to grow, You start to learn how to pick your head up from the laying down position. Your cervical curve will form in a lordotic curve, so it's going to bend to the anterior. The lumbar curve starts to form once we start to sit up on our own, and further starts to form as we learn how to cruise and finally how to walk. Now, space between most of the vertebrae, you'll find intervertebral discs. These help separate the vertebra from one to the other and also form holes in between the vertebrae to allow the nerves to pass through both the left and to the right. These are spinal nerves we'll talk about mostly in the spinal nerves and the spinal cord chapter. Very simply, each disc, if you can imagine, is shaped very similar to a jelly donut, where the outer ring of the donut is always known as fibrocartilage or the annulus fibrosus, which is going to surround a very soft, pulpy nucleus, usually more fluid or even gel-like base, called the nucleus pulposus. You'll have hyaline cartilage that lines both the top and the bottom of the disc that helps adhere it to the vertebra above and below. These are found between the second cervical vertebra all the way down to the sacrum. You have rudimentary discs in the sacrum and the coccyx, but eventually they will fuse once you hit the age of about 24. These are used to help absorb shock and create space between the vertebra. They're very good for compression, they're very good for elongation, but unfortunately the fibrocartilage in particular is highly susceptible to rotational forces, which we'll get into when we finally get into the joint chapter. Here we see an example of the vertebral column. This is what we call a motor unit, which is very simply one vertebra above with the disc between and the vertebra below creates a vertebral motor unit. Very simply, you're going to see the very typical features of the vertebral body, followed by the disc in between in the anterior, and then you're going to find the spinal canal, which will be formed between the anterior and posterior elements of the vertebra themselves. So in the anterior, you see what's called the vertebral body and the last vertebra there. You see the posterior portions, which we had talked about before, the spinous processes as well as the transverse processes. That's going to form the vertebral canal to allow the spinal cord to pass through. You'll find little bridge-like pieces that will actually attach the square-like vertebral body to the spinous process and the transverse process known as the pedicle. The lamina is going to form the actual processes that will fuse to form the spinous process. We had looked at the spina bifida. It's the lamina here that a lot of times will not fully ossify and become more cartilage, or actually have an open space. We started talking about the spinal myelomeningocele, where the spinal cord starts to grow through that particular spot. It's the lamina that does not fuse together from the left and right portions of the vertebra to form the spinous process. When we don't have that, that's when we start getting the spina bifida. Almost all vertebrae have very common structures and common characteristics, but a few characteristics will differentiate one type of vertebra from another. For example, when we look at the cervical vertebra, we have 7 cervical vertebrae, we have 12 thoracic vertebrae, 5 lumbar, 1 sacrum, 1 coccyx. For the cervical vertebra out of the 7, the first 2, known as C1, C2, are known as the atlas and the axis. The first 2 cervical vertebrae are vastly different from the other 5, but they all have what's called transverse foramina. They're found on the transverse process, as we hold that passes through on either side of each cervical vertebra, where the vertebral artery will pass through. Also, C3 through C7, and we number them very simply by the first letter of the particular region, and down by the number starting from the most superior down to the most inferior. So we have C1, 2, 3, 4, 5, 6, 7. We have T1 through 12 and L1 through 5. We also label different areas of the sacrum, in particular where the nerves will pass through different foramina, as S1 down to S4, possibly even S5, and coccyx would be coccyx 1. One other particular part of the cervical vertebra that's very unique is they have what's called uncovertebral joints, also known as look like more like cat ears on an X-ray. The uncovertebral joints are significant because the neck itself has a very wide range of motion. It helps stabilize certain motions throughout the cervical spine. So let's look at the characteristics of the cervical vertebra. Now we're going to jump around a little bit here on this particular slide. What I want you to look at first is the upper right-hand corner, looking at a typical cervical vertebra, and I'll show you how that differs from C1 and C2. Every vertebra is going to have the vertebral body, the pedicle, the facets, the lamina, and the spinous process, as well as the transverse process, but they'll be formed a little bit differently. So here in the cervical vertebra, you're going to see a small vertebral body, followed just laterally by the pedicle, then by the facets, both superior and also inferior, which is not shown there. The transverse process will branch off, in this case off of the pedicle and the vertebral body, followed by the lamina and then the spinous process. And in this case, in the cervicals, you have what's known as a bifid spinous process. Very simply, it splits. In the thoracic vertebra and the lumbar, it'll be fused. It'll just be one particular portion of the spinous process. Now, this differs a bit when we look at C1 and C2. C1, or the atlas, is going to basically hold the skull atop it. That's why they call it the atlas, as he's holding the world on his shoulders. It's going to be a little bit different. It's going to be the lightest out of all the vertebrae that we have. Very simply, it's not going to have any kind of vertebral body because there's no disc between occiput and C1 and no disc between C1 and C2. When we talk about joints, we'll talk about why that particular setup is there. Very simply, it's going to have two lateral masses on either side. This is going to hold the superior and inferior articular facets, and they're going to basically articulate with the occiput and C2. Notice there's no body here. All we see is what's called the anterior arch, and there's a little articular surface for what's called the dens of the axis. It's going to be a pivot point for C2, which is also known as the axis. There is no spinous process. You have a posterior arch. You will find to be a groove for the vertebral artery and the first spinal nerve in the cervicals. If you remember from the last chapter, we talked about the posterior ponticus. This is where that occipital ligament will pass over the groove to hold the first spinal nerve and the vertebral artery in place. If you look at the two bottom slides here, you're going to see both the superior and a lateral view of the axis. It is also going to be significant in that it has what's known as the dens. It's going to be a superior outcropping that's going to articulate with C1. It allows a pivot point as C1 will rotate on the axis. So we see a lot of flexion and extension, which we'll get to, like forward and backward motion on the occiput on the atlas, whereas we see a lot of rotation between C1 and C2, the atlas and the axis. Now, aside from the dens though, C2 will have the same characteristics as the rest of the cervical vertebra. It will have a body, it will have the transverse foramen for the vertebral artery, it'll have pedicles, it'll have the lemma, and also have the transverse processes as well as the spinous process. Here we see all 7 cervical vertebrae stacked upon one another at the posterior view. So you can see the bifid spinous processes from C2 down to about C6. C7 will have a little bit of a similar articulation as the thoracics, whereas it can be almost like a transition into the normal spinous process instead of the bifid. Now what's hidden a little bit from here are the transverse foramen on either side, except for the atlas. Very simply, the vertebral arteries, the left and right one, will snake through those transverse foramen. It'll go through the atlas in particular and then hook backwards across the groove as it goes up into the occiput. But you can see very easily how the atlas will sit on top of the axis, and you can imagine the occiput resting right on top of the axis itself, of the atlas itself, which allows a frontward and backward rotation, flexion, extension, whereas the dens will articulate with the anterior arch of the atlas, which allows quite a bit of rotation left and right. What's not shown here are the oncovertebral joints, which you'll see in the next slide, but this will form, again, a lordotic curve, which means it'll curve to the anterior. This is something that you develop as you learn to pick up your head as a baby. So you can see, again, the superior view of the atlas as well as the typical cervical vertebra. You can also see on the bottom diagram here, if you look, there's going to be 2 little hooks just above the vertebral body. If you look at the left bottommost picture there, those are known as the oncovertebral joints. Those will articulate with the vertebra just above. Again, help stabilize the cervical spine due to the lack of abundant muscle that we have in the neck versus, say, the middle back and also in the lower back. We have more stability in those particular areas because there's more muscle to control motion, where the neck and the head tend to be a little more unstable because there's less muscle mass to keep things in proper position. Here we see the thoracic vertebra and its characteristics. We have 12 thoracic vertebrae, numbered from T1 as the most superior down to T12. This forms a kyphotic curve, which means that it's going to bend to the posterior, and we're born with this. So this is developed mainly because of the rib attachments in particular. But very simply, the thoracic vertebra will have your vertebral body, have the pedicles, have the superior and the inferior articular facets. But in addition, you're going to have also demifacets that will be for the head and also tubercles for the neck of each individual rib. So each individual vertebra will have a pair of ribs on either side, both left and right, whereas the head and neck will attach or at least articulate with the superior and inferior demifacets of the vertebra above and below, as well as the tubercle for the neck of the rib in particular. The thoracic vertebrae tend to have spinous processes that tend to be long and may actually project downward and basically line up to allow proper ligamentous and tendon attachments. Here's a close-up shot of the right lateral view of a typical thoracic vertebra. So again, you can see the vertebral body forming a nice cube-like structure there. You'll find a intervertebral disc both above and below the vertebral body. You'll find the superior vertebral notch, as well as superior demifacet, as well as an inferior demifacet on the inferior portion of the vertebral body, as well as the inferior vertebral notch. The notches will form the little holes to allow the spinal nerves to pass through, both left and right, which will be continuous with the central canal formed between the vertebral body, the pedicles, and also the lamina. You see that the articular facets will also face more in a coronal situation. You'll find the facet for the tubercle of the rib on the transverse process, so they'll project laterally and also anteriorly to a certain extent as well. And you see the spinous process will actually dip down quite a bit past the plane of the vertebral body. This is very characteristic of the thoracic vertebra. Now, lumbar vertebrae tend to be the largest and the strongest of the vertebral column because they hold most of the body's weight. We have 5 lumbar vertebrae named L1, 2, 3, 4, 5. L5 will be your strongest lumbar vertebra since it's going to be on the bottom and it bears the most weight. You will find discs in between the individual vertebra. So you have the very common characteristics of almost all the vertebrae, except they tend to be a lot larger and more massive in almost all of the aspects. So you see the vertebral body tends to be just a fairly large, still cube-like structure, very large though. They have the pedicle tend to be very stout, be continuous with the transverse process, as well as the bridge between both the superior and the inferior articular processes for the facets at the same time. And the spinous process tend to be a little more blade-like and straight posterior than the other vertebra. They tend to stay within the same plane of the vertebral body. And you do see that the facets will actually change position a bit. So very simply, they tend to be more sagittal, especially in L1, 2, 3. You start getting into L4 and L5, they tend to change more so to the coronal plane, so they will start to deviate a little bit. And there's a reason for that when we get into joints, why we have that particular setup. It allows for a certain amount of both flexion extension and also a certain amount of rotation found in the lower back, which is both helpful but also detrimental to the discs themselves, which we'll get to a little later on. And to round out the vertebral column, as we just mentioned, the lumbar spine as well. The lumbar spine will be lordotic. You'll come down to the next kyphotic curve, which will be made by your sacrum. The sacrum starts out as 5 vertebrae, but starts to fuse between the ages of 16 and 18. Now, I tend to disagree with when the process ends. Most of the text I read is around 24 years of age. Our text Tertora says 30. I would test more so on the 24. It's actually part of the pelvic girdle, and the sacrum is going to move in a lot of different axes, we'll get into a little later on. We start talking about the pelvis in the next chapter. Finally, the coccyx, otherwise known as the tailbone, is also comprised of 4 vertebrae that tend to fuse around 16, 18 years of age, and they'll eventually completely fuse by around age 24, give or take. So here's a picture of the sacrum and the coccyx. So the first one we're going to look at is the anterior view of the sacrum. Some key features you'll see. The superior articular process will joint with L5. You also have what's called the sacral promontory. It's almost a projection that moves anterior and is angled ever so slightly forward to allow the proper weight of L5 and its disc to lay on top of the promontory. You have wing-like projections on either side here called the sacral ala. These will actually articulate with either side of the pelvis, in this case the ilia bone, which we'll talk about in the next chapter. You'll have different spinal nerves that will branch out between the different segments of the sacrum. As you see here, we name them the same way as if they were individual vertebrae before they were fused. So we have S1, 2, 3, 4, and 5. In fact, you almost see what we call a rudimentary disc. You can see the transverse line there. That's where the eventual fusion happened during the development of the sacrum. So you'll see different foramina, and they're simply named S1, 2, 3, and 4. You have different parts of the spinal column, or spinal cord, excuse me, that'll pass through those particular holes. If you look at the posterior view, you find the sacral canal, which is continuous with the vertebral canal from L5. You have the sacral tuberosity, as we mentioned before, is going to be a joint and also muscle attachment The actual hyaline cartilage is known as the auricular surface because it's shaped like an ear. You can't see very well here. When we get into the next chapter, you'll see how it matches up with the ilium. Also, you see both the lateral and medial sacral crests. You're going to find major muscle attachments there, in particular for the glutes as well as a few other muscles at the same time. If you look at the coccyx, it's somewhat unremarkable. It almost looks like a smaller version of the sacrum. And you see it also has its own segments there. Coccyx 1, 2, 3, and 4. Again, these will fuse by the adult age. Typically, there is one particular nerve that passes through there, the sacrococcygeal nerve, which we'll talk about when we get into the nervous system. Now, aside from the spine, we'll have different thoracic bones that help form the thoracic cage. In this case, the most anterior, we're going to find the sternum, otherwise known as the breastbone. This is a flat bone. It's going to be the center of the anterior thoracic wall. Is divided into three parts. You have the upper manubrium, which will actually articulate with the clavicle or the collarbone in more common terms, the middle body, and also the xiphoid process. The xiphoid process is going to be a little triangular blade-like projection that's going to point inferiorly. It's a major attachment for the abdominal muscles. These bones also fuse around 24 to 25 years of age. The sternum is going to articulate with the clavicles, as well as the costal cartilage of the ribs. In essence, it's going to articulate directly with the first 7 ribs, which are the true ribs, and then the last 5 ribs, known as the false ribs, are going to attach to either costal cartilage or be freestanding. Here's a quick shot of the anterior view of the sternum. As you can see, you have the manubrium, which is going to be the most superior portion. The clavicular notch and the suprasternal notch will articulate with the clavicles themselves. You find the body in the middle of the sternum itself. And finally, the xiphoid process is going to be the most inferior portion, again, a muscular attachment for the abdominal muscles. And you can see on the right side how it actually articulates with clavicle and also with the first 7 ribs as attaches to the costal cartilage. The remaining ribs, 8, 9, 10, 11, 12, are considered to be the false ribs. 11 and 12 are also segmented into floating ribs because they do not attach to any costal cartilage. They are free-floating, only attached to its corresponding thoracic vertebra. So the ribs are there for protection of the thoracic cavity, which will take care of the heart as well as the lungs, as well as the superior vena cava and also the aorta. There are 12 pairs of the ribs. Bone projections will project only a few inches from the sternum and then connect to costal cartilage, which is made of hyaline cartilage, as attached to the sternum. First 7 pairs, again, are true ribs. The next 5 are called false ribs because they'll attach to the cartilage that's not directly connected to the sternum. And then finally, have the floating ribs at 11 and 12. So each rib, with the exception of your first rib tends to be a little shorter, a little thicker than the rest of the ribs, as well as 11 and 12. They will not have any kind of facet for any kind of costal cartilage because they'll be freestanding. But the other ribs from 2 down to 10 will all have the anterior body, which will actually have ending in the facet for the costal cartilage. It'll have the costal groove, the costal angle as a change of position. You'll have the articular facet, which will articulate with the transverse process, tubercle on the corresponding thoracic vertebra, and of course the head and neck has both the superior and inferior facet, as you can see here, as it attaches to both the thoracic vertebra above and below that particular rib. So you can see how the transverse process here will match up with the actual ribs themselves. We'll actually show you these in lab. It's very easy to match these up, whether the bones are plaster or whether they're real. But you can kind of see exactly how they line up. You see how it angles downward as well from the posterior down to the anterior. The angle of the rib will drop down from the superior down to the inferior. Now let's talk about rib movement. Like I said before, the first rib is shorter and thicker than the other ribs because it will have some muscle attachments to the cervical spine. These muscles are called the scalenes. We have 3 types of scalenes. We'll get into those a little later on. They attach to the first rib and also the atlas, the axis, as well as a few of the upper cervicals. Now each set of ribs is going to have a different type of motion based on the inhalation. Ribs 1 through 5 have a pump handle motion. So those of you who are seeing the old school pump handle wells, you're trying to pump water out of a bucket, they simply move up and down from the origin point, which in this case is going to be the thoracic vertebra attachment. So we take a deep breath in, basically the sternum and the clavicle help elevate the ribs, so the anterior portion of the ribs 1 through 5 will elevate. Ribs 6 through 10 have what's called a bucket handle motion. So very simply, you have a pivot point between the attachment at the thoracic vertebra as well as the costal cartilage. So very simply, the most lateral portion of those ribs will raise and lower upon inhalation and exhalation. Finally, ribs 11 through 12 have a caliper motion, so very simply, they swing out from the axis of where they attach to thoracic vertebra 11 and 12. So every time you breathe in, they'll spin outward and then rotate back inward upon exhalation. So disorders in particular, first one to look at is naturally any problems with the disc themselves. We'll go through this a little more so in the joint section, but let's target this here so we are talking about both the nucleus and the annulus fibrosus. So one thing we see a lot in the vertebral column is herniated discs, either due to trauma or sometimes repetitive stress, or just simply associated with aging. In these cases, what happens is that nucleus pulposus, which is formed of gel, or almost like a very fluid, like water type of substance, it starts to leak out due to a tear in the annulus fibrosus. So very simply, again, go back to the jelly donut. Just think of a jelly donut that doesn't have the hole where you poked in to squirt the actual jelly in there. So very simply, what happens is as you squash the donut, the nucleus, because it is fluid, does not compress very easily. And if any kind of part of the annulus fibrosus is torn, then all of a sudden you can shoot that nucleus pulposus away from the middle of the disc. So this creates all kinds of problems. It can create biomechanical problems. So very simply, it can collapse the disc and also cause some compression, possibly either on the spinal nerve or even on the spinal cord itself. So this kind of compression can cause issues with either numbness, tingling, or even just loss of function of a particular nerve, and oftentimes even pain. Some of these things can be fixed through either physical therapy or exercise and/or chiropractic care, but sometimes it does require some type of surgical intervention on top of that, depending on the severity of the disc. And we'll look at different stages in a few moments. So one of the things we see oftentimes in the spine is osteoarthritis. This is the calcification of the annulus fibrosus. So very simply, if there's any kind of disruption of the motor unit, which again is going to be the vertebra above and below, the disc in between, all the adjoining structures, ligaments, tendons, the muscles, the nerves, the spinal cord, everything. So oftentimes just from either injury, from any kind of forceful impact like car accident or a bad fall, or sometimes repetitive stress or just poor posture will eventually cause some disruption on these particular parts, in particular the annulus fibrosus. So what ends up happening is you start getting calcification of the outermost portions of the annulus fibrosus. If you remember Wolff's Law, you start to lay down more force on a tissue. It basically the body tries to stabilize that tissue by laying down more fibers if it's muscle, or laying down calcification if it's bone. So in this case here, you can kind of see on the right-hand side, this is an X-ray. It's a lateral shot of your lumbar spine. This is what's known as lipping and spurring. So what's happening is those outermost portions there, it's kind of moving away from the block-like structure of the vertebra, and it's causing calcification that gives a little lip on the edge. More oftentimes superior and also the inferior portion of the vertebral body. More oftentimes it happens more anteriorly than it does posteriorly. So if we look at this particular X-ray, the anterior is furthest to our right and the posterior is to our left. You can kind of see the articular processes and the spine's process just behind all those areas of the vertebral body. So what ends up happening is, if this is not corrected, and oftentimes osteoarthritis, it can take years to develop, so you have time to fix this. It will eventually fuse if not corrected. And again, we can do this through physical therapy, through chiropractic. It can also be done through surgery too, if necessary. So this herniation can go into 5 different stages. This one here, we're looking at an MRI. It's a lateral shot of the lumbar spine and the sacrum towards the bottom. Quick crash course on MRI, very similar to what we're looking at here is fat content to differentiate one kind of biostructure from another. So as you can see, this is a slice, this is a sagittal slice of the lumbar spine. So what you're looking at very simply is there's going to be a very white portion there, dead center of the slide here, that's going to run from superior to inferior. That's going to be the spinal cord. You're going to see darkened areas, looks disc-like. These are your discs. In between the block-like structures, they're a little more on the grayish side. Those are vertebral bodies. So again, we're looking at how well the disc looks compared up against the spinal cord. So naturally, the first kind of stage in the disc is the normal disc. Normal disc should have a little bit of water content in the center, with a little bit more of a blackish type of situation on the MRI here. So if you were to look at the vertebra, if we look at the sacrum and counterweighs upwards, it's the sacrum, which is going to be the little kinked portion down towards the bottom end of the slide here, most inferior. Is going to be L5, then L4, L3, L2, L1, going from the inferior to the superior. So if we look at the disc above L1, it's somewhat normal. It looks very gray in the middle, which is what you want. And you notice that it stays within the confines of the vertebral body above it. Doesn't stick any further in the anterior, doesn't stick too far into the posterior either. Now the first indication that we see that the disc is having some issues, we start seeing a bulge or a swollen disc. So if we look at the disc third from the bottom, that's going to be between L3 and L4, that one's starting to swell a little bit. You start to notice, especially in the posterior portion, as it goes to the little whitish area in the spinal canal and the spinal cord, it's starting to push a little bit in that particular area. Now this is the beginnings of a problem. The next stage we have is what's known as the herniation of nucleus pulposus. So we see that at the disc between L4 and L5. You can kind of see, or kind of imagine, it's getting a little bit, quite a bit compressed, and it's bulging to both the anterior and also the posterior. We have a herniation of nucleus pulposus when that pulposus moves away from this original spot in the middle and migrates somewhere else. If it bulges and just swells up a little bit, but the nucleus stays where it is, it's just a bulge. The next stage, though, is when that starts to move. That's called herniation. Now, that's still not quite as serious, even though it might press upon the spinal cord or press upon spinal nerves. The next problem you run into is what's called an extrusion. So you can see a little bit of an extrusion as it goes above and below the plane of the disc, at that same disc at L4, in particular if you look at the posterior elements. You notice that disc is kind of dripping a bit, both to the inferior and also a little bit to the superior as well. This is known as an extrusion because it's going into the spinal canal in particular. This is a major problem. More often times than not, you can get away with doing physical therapy or chiropractor, even just full bone exercise, but occasionally this may need to be snipped through a discectomy, through a surgical intervention. The worst thing that can happen here is what's known as a sequestration, where that particular part may actually snap off and go free floating into the spinal cord. This is a direct surgical intervention. So very simply, this goes in the following stages. It starts at normal, then it may bulge from any type of injury or repetitive stress. You get herniation of nucleus pulposus, which we know if you tear the outer covering of a disc, the annulus fibrosus, it starts to migrate away from the center. If it gets too far out, it goes away from the plane of the disc itself. It's known as extrusion. But if a piece were to break off, and I have seen this, it can cause massive kind of problems and cause infection, inflammation all through the spinal cord. It can be very detrimental to the patient themselves. That's what's known as a sequestration. It's free floating up and down in the spinal canal. Now, if you recall, I talked about different types of curves that we find in the spine, some of which we're born with and some we actually develop normally through our stages from an infant through adolescence. So normally we're born with two curves, both kyphotic, which means that they curve more to the posterior. That's going to be the thoracic curve as well as the sacral curve. We have two lordotic curves that we develop as we grow, one in the cervical as we pick the head up, and also lumbar as we learn to cruise and eventually walk. But occasionally, though, we want to have some problems with the curves where the curve is either absent, or let's say the curve bends in the wrong direction. So if you were to look at someone's spine from the lateral side, again, you see two curves bending to the posterior, two will bend towards the anterior. If I were to look at someone dead on, we call an anterior posterior view, we should see all the spinal structures line up in exactly a straight line, looking from them anterior posterior. Some of the disorders that we run into, and unfortunately we find this more so in women and men, although men are not immune to this, you get what's known as a scoliosis. This means that there's an increased lateral curvature. The strange part is this: when you start seeing a scoliotic condition from the anterior posterior view, that oftentimes will straighten the curves out on the lateral view. So for example, if we have scoliosis in the thoracic spine, let's say it bends to the left, when I look at someone from the anterior posterior position, we see that curve. If I were to turn them and look them laterally, all of a sudden that thoracic curve looks like it went away, which means the kyphosis reduced. Other types of disorders we find in the spine are what's known as kyphoses or lordoses, and there's different types there too. So you have either a hypo, which means not enough of a curve, or a hyper, which means too much of a curve. So you can have a hyperkyphosis, more oftentimes found in the thoracic vertebra. We often find times these with bad compression falls, or if someone gets struck in the head, or also in older segments of the population, especially women in particular, where there could be a compression fracture, and then very simply the block that used to be the vertebral body turns into a triangle from the compression, and it forms almost like a hunchback. Oftentimes we do see in lordoses, we see either a hyperlordosis, most oftentimes in the lumbar spine. And in one case in particular, hyperlordosis is expected. We find this in the pregnancy, where obviously as the baby weight starts to pull the pelvis and the lumbar spine forward, that it can increase the lumbar curve. You can have a hypolordosis as well, where just the opposite happens, where it starts to straighten out. Now this can be a problem, especially if you have any kind of problems with the disc on the posterior side. And you can actually increase the pressure on the disc and actually cause bulging and possibly hernia discs as well. And let's take a look at those curves in a couple seconds. So start from left to right. So this is a severe form of scoliosis. So you can see here that this young lady has a curve to the right in both the lumbar and also the thoracic curve. And a lot of times what ends up happening is your body tries to compensate for these. So always try to keep your eyes level with the horizon. So more times than not, you'll see one curve going one way and almost another curve going the opposite way, trying to compensate so this way you're not walking over tilted. Sometimes you'll see people get surgeries for this. They'll get what's called Harrington rods, which uses titanium rods. They'll try and straighten out the curve as quickly as possible, or at least reduce any further aggravation of that particular curve. Unfortunately, we do see this more so in women than men. It's about a 4-to-1 ratio. I do have some patients that have Harrington rods. I had one patient in particular who broke her Harrington rods just from wear and tear and because of the aggressiveness of the scoliosis as well. The middle portion here, you can see the kyphosis, where very simply it's a very exaggerated thoracic curve. Again, you see this mostly in the elderly, although you do see some people that are born with this particular anomaly at the same time. You can see on the far right, you can see a hyperlordosis, where very simply the lumbar spine curve is drastically increased. This is what's known as a swayback. So again, we see this oftentimes with pregnant women, but a lot of times you see this too with people that are severely overweight. You see with men with the beer guts quite a bit because almost the same orientation where the body fat goes. Again, this does have a negative effect on the lumbar spine because usually the body will compensate and will straighten out other spines to try and balance things out as best possible. So here we see two different types of scoliosis. We have both a functional and a structural scoliosis. The difference being on the left here, this is known as a functional scoliosis because there's no structure that's preventing this from straightening out. More times than not, this can be due to some type of general anomaly where muscles simply are too tight on one side versus the other, or this can also be something that's gained by certain patients. I know in my generation in particular, the one-arm backpacks were very popular, so you see a lot of people that are around my age that have a formed or functional scoliosis just simply from holding a backpack over one shoulder. And those of you who have done this before, which I know most of you have, you hitch the one shoulder up. So what that does is it tilts you away from that particular spot, so it will tilt the curve. Your brain and your spinal cord will react to this over time and perceive this as normal, and oftentimes will not fight to reorient itself back into a more straight orientation. So again, functional scoliosis, which means where the muscles are simply too tight on one side versus the other. We see this oftentimes when people do a lot of driving, a lot of computer work too. They tend to lean to one area more so than the other. Again, you can develop a functional scoliosis. These are fixable. It does take time, however. The other type of scoliosis that we see is known as a structural scoliosis. This is where the actual vertebrae themselves are not formed correctly. More oftentimes than not, we have two sides of the vertebral body is formed from somites. So these are basically mesenchyme and then cartilage. Eventually these will fuse into the actual vertebra. Oftentimes one somite may be missing. So we actually form what's known as a half vertebra or hemivertebra. These are triangular. So those of you, I'm sure you remember back when you played with blocks as a kid, you try and take some cubes and put a triangle in there. It's not going to straighten out no matter what you do. And unfortunately, there's no good way of fixing this. I know there's some experimental things of trying to put in a cage or put in different types of replacements for the vertebra, but I've not heard of anything that's really too successful as far as trying to fix a structural scoliosis or the hemivertebra. Unfortunately, people like this, they're generally stuck in this particular position. Other types of disorders we had talked about last chapter was spina bifida. So very simply, it's a general defect where the lamina do not develop normally. So in some cases, you can have, it's a very minor type of problem like spina bifida occulta, where very simply the lamina will come together but don't fully fuse, but there's still matter there, in this case cartilage. So it still provides somewhat of a wall to keep or contain the spinal cord within the spinal canal. But occasionally that doesn't fuse at all, and it does leave an opening there. This is what's known as spina bifida manifesta, and oftentimes you have either a meninges myelocele or other kind of outcropping of the spinal cord. If this gets past the skin layer and is exposed, it can be fatal to the baby. So this forms a cyst-like sac. CSF can actually fill into the particular meninges, cause a lot of pain and disrupt the spinal cord, and also the nerve roots as they protrude from the spinal column. So here we see a spina bifida manifesta with the meningeal myelocele. Sometimes they'll actually try and operate this on babies while they're still in the womb, which can be very successful but very traumatic for both the baby and also the mother. Or what they'll do is they'll try and fix this almost immediately after birth. But unfortunately, if left exposed, the baby has minutes to live. Compression fractures, as I talked about before, you oftentimes see this in the elderly, but you oftentimes will see this too with construction workers that take a severe blow to the head. There's also some other types of car accidents that can also cause compression fractures. Bad falls, falling on tailbone can also cause this kind of issue as well. But usually there has to be an underlying condition to accelerate this. A lot of times osteoporosis, as we mentioned before, the bony mass starts to depreciate, so you imagine the force of the body coming down on the vertebral body can literally compress the bone itself and cause what we call anterior wedging. If you kind of look at the 6 vertebrae that are there, these are thoracic vertebrae. We're looking at the third one down from the superior. It has almost like a fish-like quality to it, where you kind of see the fish, facing to the left. This was known as anterior wedging. So again, just like the hemivertebra, if we don't have a good block-like formation on the vertebral body, then the vertebra above will not stack properly, and this can cause a lot of discomfort and a lot of compression on the nerves themselves. It cause some problems there with any kind of either sensation or possibly motor function of those particular muscles or other organs that are going to be innervated in that particular spot. For most patients like this, bed rest is the first thing you do, so it doesn't aggravate anything further. Sometimes a little bit of PT, and occasionally they get a kyphoplasty or uteroplasty, where they'll try and inject more calcified fluids into the actual fracture to try and beef up the vertebral body itself. Some people have great success, but unfortunately, as people get more in advanced years, this is not the best option because it opens them up to infection as well as other kind of side effects. Now this one I throw up here only because it gives you an idea of how detrimental any kind of upper cervical injuries are. Now this one here is what's known as a hangman's fracture. This is what happens when you fracture either C2, remember it is the axis, or C3. Back in the day when, well, actually there's slower hangings that occur around the world now, but back in the day, if you had a hangman that was very good, this caused a very quick fracture of the vertebra. It would basically cut off the spinal cord and you would die pretty much instantly. But occasionally, if you had a hangman that either didn't like you or unless he wasn't very good, very simply, this could actually paralyze you first, and you very slowly would asphyxiate after. So this particular case, this is one of mine. This is actually something that I picked up from my malpractice insurance. This particular person got injured in a car accident. It was a very severe whiplash injury, and her head actually hit the steering wheel very hard. As before airbags were made mandatory in most cars. So she fractured her C2 and also the C3. So you can kind of see, if you look to the left of the diagram here, this is an MRI. There's a little bit different, we call weighted image, whereas before we looked at MRI of the herniated discs, the spinal cord was white because we're looking at fat content. And this one is looking more at water content to differentiate one aspect from another. But you can see to the left-hand side, there's going to be the anterior portion. You see almost like a finger-like or like a thumb-like projection. That's going to be the dens of C2. You see that that's been fractured. You can see the disc just below it. It's going to be outlined a little bit by a darkening spot of the annulus fibrosus. You can see it slipped forward, pulling the posterior elements. In this case, the facets as well as the pedicle and the lamina forward. And you can obviously see the kink there in the spinal cord. This person was able to be saved. This person was paralyzed temporarily. They had to put bolts as well as plates to basically solidify the position on C2 onto C3 and C4, and also they plated the posterior elements, in this case the spine's processes, to keep everything together. Now this young lady lost almost all of her mobility at the head and neck, but she was alive. From my understanding, she does have still have some numbness and tingling down through the legs into the arms, but she is fully functional. This case is roughly about 15 or 16 years old. Other types of anomalies that we see sometimes in the axial skeleton, we may see an extra vertebra, we may see an extra joint, or a large outcropping of a particular process that just may be different from the others. So especially down in the lumbar spine, the sacral area, we see different types of congenital anomalies where you're simply born with these. This is not a disease process, it's just simply something either stopped forming or it formed too much. So oftentimes we'll see a particular type of anomaly called a lumbarization, where very simply there is going to be the sacrum will not fully fuse. So as we said before, the sacrum is made of 5 individual segments that fuse around 16, 18 years of age as they start and finish by the time you're 24. Sometimes the lumbarization is the top portion of the sacrum does not fully fuse, and there's a rudimentary disc still there that's known as lumbarization. Just the opposite, you can have a sacralization, where very simply you can have either L5 will fuse with the sacrum or oftentimes with the ilia. In this case here, judging by the arrows there, if you look very closely, there's an X-ray known as a lumbopelvic. We're looking straight on anterior posterior on the L5, as well as the sacrum and also the ilia. So what happens is the transverse processes on either side of L5, they elongate and form pseudojoints with both parts of the sacrum here. Or oftentimes what happens too is the disc could be missing from L5 and it can fuse to the sacrum. For most people that have this, there's not much reduction in any kind of mobility, and often the nerves are still okay, they're not compressed. The body still finds ways of getting things to work in that particular aspect. But in certain motions though, in certain types of sports, this can cause a lot of disruption, especially for extreme sports. Any kind of things that involve jumping or getting hit, a lot of times can cause a lot of disruption, a lot of pain in these particular aspects. The fourth thing you have is you can have a 6th lumbar, where very simply is just an extra lumbar there. This causes some issues only when we deal with the lordosis. It does increase lordosis of the lumbar spine, so for some people that may be overweight already, this can put some more pressure on the spinal cord itself. That unfortunately just takes PT. They will not take this out, so to speak, through surgery. It's just something the body has to basically acclimate to. The last thing I want to mention here is what's known as asymmetrical facet syndrome. So what happens is the facets in each area of the spine, if you look at individual vertebrae, you can see how they stack up. So very simply, when we're talking about the cervical vertebra, they're going to line up in about a 45-degree angle. They're going to face superior, inferior, and also a little bit to the anterior and posterior. They have no laterality to them. That allows for proper motion of the head and neck in all directions of motion, flexion, extension, lateral flexion, which means tilting side to side, and also rotation left and right. The thoracic vertebra will simply be only in the coronal plane. We get down into the lumbar spine, as I mentioned before. They will start out more so in the sagittal plane, so they're going to face medial and lateral in the top 3 lumbars, and they start transition over into the coronal plane, so they're going to allow for proper motion from tilting left-right, forward flexion, and also extension, but also rotation at the same time. But occasionally what ends up happening is in asymmetrical facet syndrome, one will lay in the sagittal plane, one will lay in the coronal plane. This is very painful for these particular people. It's not anything to be surgically fixed, although I know there's certain experimental things in place. But as I mentioned before, one is literally at a 90-degree angle to the other, so there is no motion that will not be uncomfortable for these particular people. So again, these are congenital anomalies. There are quite a few others that are too numerous to count, but just to give you an idea, a lot of times that there are a lot of things that have to go right just for the bones themselves, at least for the axial skeleton. So count yourself fortunate, and more times than not, with people that have a congenital anomaly in one spot, they usually have a handful of others somewhere else as well. This is usually due to genes either being turned off too soon or left on too long, but we do see a lot of different types of congenital anomalies all throughout the skeleton. So this ends chapter 7. We'll pick up on the appendicular skeleton on chapter 8.